He is the head of Chief Cochlear Implant Surgeon at Ganga Ram Hospital. I think I mangled that up, Shalabh, so badly. But Shalabh is amazing. He is going to share with us an ENT's perspective on COVID today. And Shalabh, it is really a privilege and a pleasure to have you with us. And also for, I mean, a lot of people don't know, but Shalabh and Shikha are both very active in Vasant Vihar. They have been supporting us throughout as a community. And you know, of course, at Ganga Ram, he is already helping everyone. He's fantastic, not only as a physician and as a doctor, but as a human being. Shalabh, it is a privilege to have you with us today. Thank you so much for joining us.
Thank you, Bhavna, for inviting me. I would like to thank CII and CII IWN, the Delhi chapter, for having me here. And I think you guys have been doing such a great job in this pandemic with all the doctors and personalities whom we have interviewed. And I've been lucky to catch most of it.
Wonderful. Oh, we're so pleased that you did that. Thank you, Shalabh. Okay, Shalabh, we're going to dive right into it. So an ear, nose, throat, an ENT's perspective, I think, is so imperative right now, because this is, it's the point of entry. This is where the disease enters from, because it's, you know, viral, it's airborne. Shalabh, I mean, from hygiene to prevention to, to taking care of things. Let's just start. You start somewhere with the nose start and tell me, what do we do?
Well, you know, essentially we have to understand this is a respiratory illness, and the point of entry is the nose. Very rare the mouth maybe, but most of the time it has to be the nose, because you're breathing in the virus in the air. So if you can protect yourself, and that's why most of the patients end up starting off with symptoms to do with the nose and throat. So the first thing is either an itchy throat, you know, or a throat pain, and that itself is the first sign. A lot of people, patients who fall ill, get this itchy throat for a couple of days, but they think that is just an allergy or something that happened, the same allergy as I had last year. And it's only when the fever comes that they get themselves tested and find out. And in those 2 days, they manage to infect other people in the household. So the thing is that I think very important point that you made is that ENT being the entry point, any ENT symptom should be treated with a high degree of suspicion, and immediately they should isolate until they have proven that they don't have COVID. And once it comes to preventing entry, the most important thing is best is if you don't get the virus, you know. Of course, you can be vaccinated, but ideally you should not get infected in the first place. The important thing is wearing masks properly. Now, there's a lot of double masking and triple masking. The basic thing is that a layering with the masks does help. Wearing a surgical mask with a cloth mask on top will also help. Wearing a better mask like an N95 would be even better, but it's very difficult for normal persons to wear an N95 and do their normal household activity or their office activity. Is very difficult. Climbing up steps is almost next to impossible. And definitely people should not be jogging or going into the parks and brisk walking or exercising with the N95s, because that has caused a lot of people to collapse, and it's calamitous. I will just show you ideally that this is a surgical mask, a simple surgical mask, and it should have this, the band on top, which allows you to bend it. And then this is the simple way of wearing a mask, but it's even better if if you twist it like that.
Oh, my son always does that, and I've always told him, Shivnan, don't do that. I'm obviously doing it wrong.
Yeah, that shows that he's already right on the ball. There we go. The moment you wear it like this, the moment you want it like this, it tightens it up and let air escape from around the sides. And then on top of this, you can wear your regular cloth mask and all that. Now, the most important thing to remember is the outside surface is the one that's infected potentially. You've gone out, you've met someone. If there's virus in the air, it's stuck to the outside. Now, the mistake people make is when they take it off, they're not taking. So before you wear a mask, you should sanitize. After you remove your mask, you should sanitize. And never touch the outside of the mask with your fingers. So you take it off from here and you put it away. And then ideally, you should have these bags. These are sort of a breathable fabric or a cloth or anything that breathes, and put the mask aside put a date on it, put a day, like say Monday, and then every Monday you can take the same mask and wear it till you think a couple of times till you think it's not usable or is dirty. And the same applies to even the N95. That's what we doctors are doing. We have I have 7 masks for 7 days of the week. Of course, I wear a PAPR, the powered respirator, but most of the time, if I'm in the hospital or if I'm operating, those masks are always staggered, used every week. So it's safe to use because the virus, even if it's on the outside, dies within a week for sure.
Okay, so you rotate it. The most important principle here is to rotate.
Take the mask, give it a week to dry out in a breathable bag, and there'll be no virus left by the time you're holding it again.
Okay, so I think the key elements are: 1, make sure the nose is well covered; 2, make sure, so wear it right? Secondly, make sure that the outside is where really the protocol of removing it and keeping it is very important, so that you're not aiding in the spread of the virus, right? And the third is to clearly label it and then rotate it. Those are my 3 takeaways from this? Okay, great, wonderful. So now, so everybody's talking about the transmittal, right? The transmittal through droplets and through. So tell me something, if we are speaking, you and I, and we've got like 1 layer of mask on, let's say, especially like people are saying now, indoors also wear it. You're inside the family, you've got to wear it with your family members. So, I mean, what kind of mask, and 2, what distance should we stand at to prevent any spread? I mean, assuming that anyway, you're free of COVID, like these are protocols people are still suggesting you should still manage.
In a family unit, if all the people are secluded, sort of isolated from the outside, then they don't have to wear masks inside. But if one of the family members is going out of the home and coming back in, then that person needs to be wearing a mask at all times. But just wearing a mask doesn't help unless they are wearing an N95 and the other people in the family are also wearing it. It's very difficult. It's not possible. So most important thing is ventilation. And if I would, in fact, I would be worried myself if I had to be in a room with other people whom I wouldn't know what was the status for COVID. But if it's an open space or if it's a very well ventilated room, then I would have no problem at all. So the most important thing is actually ventilation. When people fall sick and they're isolated in their room at home, I always tell them that you keep the door between your room and the bathroom open. And if you have an exhaust there, turn it on and leave it on 24/7. So what happens is you're drawing air through the house, through the room, through the bathroom, and then out the exhaust. So what is happening, reverse airflow from that room of the person with COVID is not coming back into the house.
Back in.
It's all a ventilation. If you can get that right, be in a ventilated place with other people, sit on the balcony, wear a mask, and just keep a distance of about 6 feet, you are absolutely safe.
Okay, wonderful. So now, Doc, what do we do with, I mean, I guess the standard questions, throat is hurting, everybody's asking, what do I do for gargling? Like, what is specifically the right way to gargle, and what should be somebody doing at home now? Can you just talk a little bit about the gargling and all of that, both as a prevention as well as a cure?
For a sore throat, I would normally only suggest warm saltwater gargles a couple of times a day, the old family tradition, and it works best. If you have COVID, there's a lot of literature out there about hydrogen peroxide, diluted peroxide washes, gargles, or betadine gargles. But the problem is that all it will do is temporarily decrease the viral count in your throat. But essentially, when a person who has COVID is breathing out from the chest, from the lungs, from the nose, the virus is escaping into the air. So gargling as such doesn't really make a person less infective.
Okay.
If you're talking without
the contagiousness of the disease, but it's going to help possibly with your symptomatic relief.
Yeah, that's right.
Okay. So, Doc, I know we talked, you and I spoke earlier about oxygen concentrators, and you've been treating so many people, at home. So can you touch upon like how these, you said they're really amazing and they've been saving so many lives. Can you touch upon how it's really helped home management?
Been a boon actually, because when there was a time for about almost a month now, luckily that period is getting over, when there were almost no beds available anywhere in the hospital for money or for anything. People just couldn't get up. And then when they were desaturating, when the saturation was dropping, it was a double whammy, because they knew they needed a hospital bed. They couldn't get a hospital bed, and also a lot of the hospitals were running out of oxygen or not. So at this time, the oxygen concentrators really played a huge role, because it gives up to, most of the concentrators, if they are good quality, good companies, give up to 5 liters a minute. And that is enough for most people whose saturation is at about 88, 89. They can manage with that. Only if it goes lower than that would even a concentrator struggle. But anyway, someone with oxygen level less than 88, 85 should be anyway ideally in the hospital.
Hospital, yeah.
The patients with the concentrator, with the medication, with the steroids, anticoagulants, and all the other medicines that we actually give, luckily most of them have been able to get better, on their way to getting better now. And if we didn't have the concentrators, then a lot of those patients could not have been saved, because they would not have been able to get a bed in a hospital. And so there would have been a lack of oxygen.
Yeah, fabulous. Doc, we want to talk about nebulizers and the proper protocols with that.
So it's advisable now for anyone who's either an asthmatic, history of recurrent bronchitis in the past, or someone who's say a diabetic patient, some high risk individuals who have COVID. It's a good idea to start them in advance, means in the beginning itself, on a nebulization with Budecort, which is budesonide, which is a steroid. And giving this does help to a little extent in preventing them from developing more lung problems or getting more serious issues with the lungs later. So the important thing about nebulization is that, and even the oxygen concentrator, is that you have to keep all the tubing clean. Now, the thing is, you can't clean the tubing. So it's very important to change the tubing every couple of days. And at the same time, there is a humidifier bottle in concentrators, and with the oxygen cylinders, for example, the humidified bottles can be cleaned just with simple soap and water. And they don't really need any disinfectant cleaning, but they have to be dried. And then the water that is put in them should be boiled water. So filtered water, preferably RO, but it could be any filtered water, boiled for about at least 10 minutes on the running boil. That water is more or less clean, sterile, and that water is used. And you hear a lot about the fungus nowadays, and some of it, most of it is always seen in patients who have been on oxygen. And the reason is that oxygen wearing the nasal prongs, the dryness causes ultimately injury inside the lining of the nose and creates a small passage for where this fungus, which is sitting in the nose, goes inside. So,
Doc, is this black fungus a complication of COVID? Or, I mean, is it an outcome? Is it a complication? What really is it? And prevent it?
It's a byproduct of the situation. Most of the patients with COVID have a decreased lymphocyte count. That's a white blood cell which fights against infection. So their immunity is down because of COVID. Now, some of them are diabetics. Some of them are poorly controlled diabetics. So they have a low immunity. Kidney transplant patients, any person who's on steroids for any reason. And these patients are much more prone to getting, and diabetics, and all these patients, the moment they start having a desaturation of oxygen, they go on steroids. Steroids increase the blood sugar and decrease immunity further. And then, some of them who get really ill, they use those drugs, tocilizumab or rivaroxaban, and they kill the immunity completely. So the problem is that the moment the immunity goes down, all these strange kind of bacteria and fungus which actually live inside our body, some of them are in our nose, never trouble us. They get in, and once they find a port of entry, then they start spreading. So I've been treating mucormycosis patients since I came, so over 20 years now, more than that. The thing is that they are rare, and until now they were rarely seen. And they were usually diabetic patients, usually farmers working in farms. That's where sometimes the fungus, I think, comes from. And now we are seeing much more of this, but it's not because of COVID per se. It's just the unfortunate product of all the circumstances that bring down the immunity in these people, and they catch this infection. And prevention, to tell you the truth, the only real way is nasal hygiene during COVID episode and post. So patients, like I said about the humidifier bottles, that's very important. Changing the tubing regularly is very important. And then at the same time, for example, if the patient has diabetes, then keeping the sugars absolutely under control with the help of physicians at the same time. All of that is very important in preventing mucor. And from the point of nasal hygiene, it's basically humidification or moisturization. So there's something called liquid paraffin. It's an oil, a couple of drops in the nostrils twice a day. Helps keep the inside of the nose moist, prevents the crusting that comes from wearing the oxygen, the apparatus all the time, and that prevents drying. And if there is no drying, then the crusting doesn't form. And if the crusts don't form, the problem is when the crust forms, they separate out from the lining, leave a raw area, and then the fungus gets in. So as long as you keep stuff inside moist, there should be no problem. And of course,
Okay, great. So do you want to quickly touch upon some hygiene practices that we could follow for nasal, throat, whatever?
if you have any nasal issues, or if you are on a nasal, if you are on nasal prongs for oxygen, or if you are on a oxygen for any reason, then using a salt water saline spray to wash out the nose or clean it up a bit, and then using some moisturizing agent like liquid paraffin or even a couple of drops of almond oil is what people use, and that's absolutely fine. All of these things go a long way in improving and keeping our nasal hygiene up to a good level so that we don't get this infection.
Perfect. Wonderful. Doc, we're going to go right into audience questions now. So we're starting with Glossy, actually. Can sinusitis predispose to having superimposed fungal infection in COVID?
Sinusitis per se would not predispose you to that, but if you there are different kinds of sinusitis. So now there's bacterial sinusitis, which is what we all know about. Then there's also this allergic fungal disease, allergic fungal, where they have these small fungal balls inside the sinuses, and that's usually people who have a severe allergy to the fungus. And the fungus is present in the air. We all have it in our noses all the time.
Yeah.
But if you have a strong allergy, there's a reaction, the tissue, the fluid, it fills up inside and the polyps form. And then this disease gets entrapped inside. These patients, if they have an immunity compromise and the immunity is down for a long time, that fungus, it's not an infective fungus, it's not invasive, but it can turn invasive. Usually those will not be mucor, then that will be more of aspergillus, which is another invasive fungal disease and probably just as bad as mucor is.
Okay. From Sonali, for 2 masks besides the N95, the regular mask, can it be 2-layer or should it be 3-layer as well? So if somebody's doing double masking, basically.
I think 2 layers is more than enough. Taking care of 3 layers is not easy, I think, and also in this heat and the atmosphere, you can sit in an AC room and wear 3 masks, but outside, if you wear 3 masks, you'll be sweating inside. And the moment you sweat inside and you are wet inside the mask, the purpose of the mask is lost.
True that. Okay. From Deepak, he would like your office address and your phone number. We can share those details with you at the end. Thank you. From Sadhna, my 28-year-old son had COVID a month ago. Fever, throat pain, irritation. It's a month now. The irritation is continuing. Is that okay, or does something need to be done?
He probably has a little bit of a nasal issue following the COVID. So maybe a little bit of steam inhalation or even a saline nasal spray for a couple of days should go a long way in getting him back to normal. The throat irritation usually will be either from a little bit of a post-nasal drip.
Nasal drip, yeah.
So if you can take some steam or use a saline spray, that should help.
Okay. From Tanuja, where do we keep the stored masks such that it does not spread the virus from the breathable bag?
The virus doesn't spread like that because no one's breathing inside it. It needs air to move in and out for the virus to spread. So even if there's virus on the mask, even if there's virus on a mask, as long as you are not touching it with your hands and you drop it into the bag, and then you just put the bag away for a week, anywhere, in any room, in an open closet somewhere, that's absolutely fine. It won't spread from there.
Okay. From Sonali, I think you've touched upon it, but I'll just read her question. Please explain causes, symptoms, precaution, prevention, and cure of black fungus.
That's a lot. It'll take an hour to go.
Let's headline it, Doc, in the categories.
Best thing is just to control your sugars and not end up in a position to have this black fungus, the mucormycosis. It's a bad disease. And especially right now, as far as I know, there's only one drug there are 2. There's an oral drug called posaconazole, but there's also this the amphotericin B. It's a very strong agent, very toxic drug, but it's the only one that really works. Unfortunately, right now, there's such a severe shortage that a lot of patients aren't able to get it. And
procurement, supply is an issue. Okay. From Achla, Dr. Shalab, I had COVID 1 month ago. Now I am negative and fine, but since a week, I'm having mild headache, sometimes having little stomach aches and burps. Please suggest some remedies.
Headache, it may be just gastritis, maybe due to azithromycin or some antibiotic or some zinc and all the stuff that people are taking during the COVID. So it could be just that. But if it persists, it's always good to get that routine blood test done, just the ESR, the CRP, and the D dimer. And we have to understand that this illness isn't like other colds, common cold. It doesn't go away in a week's time and leave us fine. A lot of patients would continue to have some sort of issue for almost 3 to 6 months after COVID is gone, before it actually, the effect is gone completely.
Okay. Thanks, Doc. Okay, what are the symptoms of black fungus vis-a-vis ENT from Gunilla? Yeah.
It's basically, it starts from the sinuses, and what it can do is from the sinus, it can either go up, so it goes into the eyes, so you get eye swelling or vision issues, and it could go up from here, it can go up to the brain, so then there would be massive headache and loss of patient's mental faculties. And if it goes down, then it comes into the palate and the teeth, so you can get a loosening of the teeth or a blackening of a part of the palate. That's the insight in the mouth. That these are the normally the signs that you see in patients. And of course, they can have some bleeding also initially, but later on there's no bleeding from this disease.
Right. Okay. Thank you, Doc. Very well explained. From Angad, I was infected with COVID in November, then got my antibody test last month. It was around 6. So can I get reinfected, or are my antibodies okay? And
no, antibodies don't prevent us from getting reinfected. And even if you have an antibody count of 5,000, you still can get reinfected. So the best thing to do is get vaccinated if you can, if you're at that age that the government is allowing you. And at the same time, maintain all the same precautions to not get the disease again. Because COVID disease, unlike measles, mumps, once you have it, you can get it a second time, you can get it a third time. And there's no telling that each time is going to be easier than the last. So best is to always continue with the precautions until at least 80% of our population all over the world is vaccinated.
True, absolutely true. Especially with all these relapses now, Doc. People are getting it and then they get okay, and then in 3 weeks they're back down. Okay, from Shivani, how and when do you decide to use budesonide puff over the nebulizer?
I would say go with a puff if it's available to you, because right now there's a lot of availability issues also with the medicines. But puff and a nebulizer is almost as good as each other. The nebulizer is slightly better, but if a person starts having breathing issues, then I would prefer a nebulizer. But before they have anything, I would prefer either would be fine. There's no difference between the two.
Okay. From Abhishek, are Addison's patients at a higher risk for black fungus infection?
Any patient with that, because of the steroid issue in that, the body's production of steroid. So yes, they can be at a higher risk for, but black fungus itself is very rare. There are so many other infections that you get before that. People in the ICU don't get black fungus most of the time. That's like maybe 1 in 100 infections or less. It's usually the bacterial infections which are terrible. And, the E. coli and the Pseudomonas and the Proteus and all these other organisms, they are the ones. So I would say that don't worry about the black fungus so much. There are lots of other things to worry about.
No, and I think you're right. And with the problem with some of these bacterial ones is the recurrence. So you really have to make sure that they've been properly taken care of. Doc, okay, so there's somebody who has private messaged me. He's asking about an eardrum infection. And he's saying, I've been taking medication for 4 months and all different doctors, but the problem is not corrected. I'm not sure how we can help him, but if you can shed some light.
It's intact and it's an external ear infection, or there's a eardrum perforation and it's a middle ear infection. So
he's saying it's a middle ear infection. Yeah.
So there are 2 types of middle ear infections. One has a simple perforation in the eardrum, and that is usually with medication. It will dry up, but it won't heal. And a lot of times it will need surgery to close it, what we call a tympanoplasty, to close the perforation and get the patient back to normal. But there's another kind of hole in the eardrum, a disease that is unsafe kind of disease, and that will not get better in spite of whatever medicine you may take. That does require surgery anyway to get the patient back to normal. So it depends on the diagnosis. If he's not diabetic, there should be no reason that they haven't been able to control the infection in such a long time.
In 4 months, yeah. So anyway, Doc, we will definitely share your coordinates at the end. So people who have specific questions like this, you can definitely reach out to Doc at the end. Okay, from Shibani, are also oral steroids. When do you usually bring them in? Also, your thoughts on ivermectin. How much of it is really useful and for how many days? There's so much debate around ivermectin, actually, Doc. You know, so
Start
what
with
are your views?
it's not on the recommended group of drugs anywhere in the world except in India.
Right.
AIMS did a study. It's not a perfect study, it's not perfectly designed, but it did show that the people who did take it seemed to get much less infections than the ones who didn't at AIMS. The staff took it, more than 3,000 of them. And so because of that and other anecdotal studies, it seems that there may be a role. It's harmless in that sense. It doesn't have any really bad side effects. So we see no harm, I think, in prescribing it to people and hoping that it does work. Probably after 6 months, we'll know whether it really works or not. Oral steroids are given to people who I think are just about to drop into that desaturation where their oxygen saturation has started to go down or is going to go down. We have to understand that we have two lungs, and between the two lungs, we have more than enough overcapacity to breathe. And even with one lung, we maintain 100% saturation. So the problem is that the moment your patient saturation from 98 or 97, whatever is the normal of the person, starts going down to 96, 95, it means already more than 50% of the lung is compromised. So the thing is that even a slight drop in concentration has to be taken seriously. And then that is the point when the steroids are started. The first 3, 4, 5 days of the infection developing, when the person gets the symptoms, is a very dangerous time to start steroids, because that's the time the virus is replicating at a very fast pace. I mean, seeing multiple thousand cells are becoming million, then billion, then trillion inside the body. If you take a steroid at that time, decreases your immunity, the viral count is going to shoot up, you're probably going to have a very severe illness. But around the 5th, 6th, 7th, 8th day is when the immune reaction of the body kicks in, the swelling starts, the inflammatory process starts, and that's the pushback from the body actually on the virus. And that is what brings down the oxygen saturation. And immediately they have to be on a good dose of steroid to cut that short at that point itself, because there's a tipping point. If the saturation keeps dropping beyond a certain point, then sometimes it becomes too difficult. If too much of swelling has already taken place in the lungs, it becomes very difficult to get people back from there.
So the timing is really important.
Timing, the understanding of the exact crucial time when it looks like a person's been absolutely fine for 5, 6 days, just a little bit of cough and a little bit of fever. Now he's fine, no fever, everything's good. And the 7th day, the fever restarts, a cough develops again, and that is a warning sign.
Yeah.
We can't really wait for the saturation to stop dropping, because like I said, the moment it starts dropping, we've already let the disease progress further.
Too far in a way. Okay, thanks, Doc. From Disha. Good evening. My husband had COVID last month on the 17th. Steroids finished on Wednesday. Kindly avoid advice, precautions to be taken, especially regarding black fungus. I mean, you might have covered it already.
It's the same, I think. Just saline nasal sprays and moisturize the nose, even with one or couple of drops of olive oil, or even almond oil.
Almond oil.
Twice a day, wash out the nose with the salt water spray, and just put in a couple of drops of that. Do it for about a month, the nose will be fine.
Okay. From Rinky, some people are experiencing hearing loss or tinnitus post-COVID or post-vaccine. Why is this happening?
No, there is a problem with the virus, because like any virus, and as a general public, you would not be aware, but I see on an average of 2 patients in a week who have developed a sudden hearing loss in one of the years. A sudden hearing loss means one that develops less than, usually in a couple of hours, like overnight. Patient goes to sleep fine, wakes up in the morning, 1 ear is not hearing. That's called sudden sensorineural hearing loss. We suspect it to be because of viral infections, and we treat very aggressively with very high doses of steroid and antivirals right in the beginning. And like any viral infection, COVID is also a viral infection, and it can also cause the same. There have been reported cases of sudden hearing loss in 1 year. And the problem is that unless you give high doses of steroid, some of them don't recover. And tinnitus is another thing, is also because of damage to the inner ear from the viral infection itself, or the inflammation that takes place after the virus is gone. And even in that, steroids would be the treatment. And it would be difficult for anyone to say whether the treatment would be curative or not. It would help for sure. It may cure the person and the tinnitus may go away, the hearing may come back. but not in all the cases.
Okay, thanks, Doc. Then again, I've got another private one. Convalescing from COVID, stopped steroid 4 days back, feet pressure in ears, sinus on the temple, cold type headaches, compromised eyesight.
That's not a good sign. So I would suggest the immediate MRI with contrast. They should seek ENT help immediately.
Okay, Neetu, this is for Neetu because she's asked this. So definitely get yourself checked out by an ENT and then get the MRI going. Okay, Doc. Doc, we are at 6 p.m. So I hope we can continue because we've got a lot more questions. Can we continue for a bit?
Yeah.
Awesome. Thank you. Okay, Shivani, your views on this new drug out by DRDO?
Yeah. It's initial days yet. We have to wait for some time for the real data to come out because they haven't, their results in the phase 1 and phase 2 trials were very promising. The phase 3 trial was about 200 people. And it seems that even there, it brought down the oxygen requirement. But what I could read is that there are a lot of people excluded from this, for example, diabetics or people with heart conditions. So a lot of people who actually end up having the problems are actually excluded from this trial because of the drug itself may not suit them. And the other thing is that it's so their methodology of using it is that it should be given in the first 4 or 5 days of the illness. But usually if a person in the first 4 or 5 days is very mild, so mild to moderate right in the beginning is when they want to give it. Unfortunately, right now we are looking for cures for people who are already in the moderate to severe disease and the later phase of disease and trying to find an answer. So whether it helps these kind of patients or not, we don't know yet. Another couple of weeks with the doctors everywhere using it. For example, it's not available. They've given it only to the DRDO. The DRDO has given it to, say, example, AIIMS and other of the hospitals they've distributed. It hasn't really come in the market yet. So
okay,
some time before all the doctors in the hospitals are able to get their hands on it, give it to the patients and see the effects.
Okay. Doc, really quickly, why are so many people who have like no previous health issues, right, still getting so badly hit and hospitalized and even dying despite both shots? Again, that's Shibani.
That's why when I talk to family and friends, I keep telling them, you don't know whom this disease is just going to pick up, and take away. And there's taken away so many people. A lot of them people who are young, who didn't have comorbidities. We don't know why it's happening, but we know why it happens. And essentially, it's because of the overactive immune system. So, for the last 1.5 years, I've been having people tell me that, we take Kada, we are taking this, we are taking that, because we want to build our immunity. And I'm telling them, please don't increase your immunity too much, because if you increase your immunity above a certain level, that immunity is the one that's going to get you. It's the immune reaction that actually ends up killing people because of the increased inflammation. So we want an immune reaction enough to control the virus infection, but not
so much.
Yeah, this time this virus for some reason has been activating the immune system in the younger people, and younger people have more robust immune systems.
Absolutely, Doc.
This time the elderly are having a slow course, oxygen saturation going down slowly. We have enough time to put them on medicine and get them back. But the younger ones are going down within 24 to 48 hours. And that's where the problem comes.
But why is that, Doc? Do you know why?
The immune system hits back very fast, very hard.
Yeah, but so I mean, I don't know. I guess the over supply of I guess we're compensating too much on the side of building our immune system, like you said. Is that why, really?
The immune system creates antibodies and the T cells, and the white cells go there to fight the infection. For example, in the lungs and the capillaries, the blood vessels where the oxygen comes and then goes into the blood. Those vessels, they get inflamed because the virus and the fight that takes place releases stuff called cytokines. And you've heard the cytokine storm. Yes. So those chemicals are released by this fight between the body's immune system and the cells. So the more the fight, more the release, more the swelling, the oxygen can't transfer through the blood vessel wall into the blood because the wall is swollen. If it's swollen like this, then nothing goes through. And that
can't permeate.
Yeah. So when we give steroids is because this disease does two things. It's because the inflammatory response, and the best anti-inflammatory drug we have in the world is the steroid. And it's for all these people who have this oxygen desaturation. And the other thing we give is the anticoagulants, because this disease is also notorious causing coagulation. All that picture that you see on the CT scan, you know, your CT score, everyone is talking about, not the RT-PCR, the CT scan score, CTSS. Say
Yes.
10 out of 25, the lungs are infiltrated, or 20 out of 25. What does that mean? That's
Yeah.
not an infection. We call it COVID pneumonia, but it's not a pneumonia. It's actually the blood vessels in that have got blocked because of the coagulation that's taken place. And that's why anyone who has an oxygen drop will always get the anticoagulant, a strong anticoagulant to blood thinner, as well as the steroid.
Awesome, Doc. Okay, from Renu Mehra, when can one start traveling after COVID?
Meaning you've had COVID and you want to travel, or you want to travel when COVID is over?
I don't think you should be traveling right now.
Yeah.
From Mr. Glossy, we go itchy throat, no symptoms, no soreness, no phlegm. Should one test?
Yes. Yes. If you are in doubt, isolate first, then test. Don't test first, wait for the report, and then isolate.
Cool. From Meg, itchy throat of COVID versus regular allergies. How does one tell the difference? Especially, so I guess a lot of people who are prone to allergies, they must be, really confused by this question.
Yeah, but the most important,
also, a lot of her family members within the home are recovering, and she's saying, should I take it as I have been infected even though I've had no symptoms? Over to you, Doc.
no, this time, most of the virus, the mutations have been so fast to spread between people that entire families have got infected. But I've had families in which 1 or 2 people have got infected and everyone else has escaped also. So it all depends on the mutation of the virus. I think the genetic, build of the person, their immune system, so many things come into play. With their vaccination status, all of this matters. So it's not necessary that you'll get infected if you are in a house, but most important thing for everyone in the family to understand is if you have any symptom, isolate first, then about what to do, then test. Don't think that I'll test, wait for 24, 48 hours, get the report, and if it's positive, I'm going to be like, I'm okay. And there are 30% false negatives. So even if you test, you're having symptoms, you test, it comes negative, doesn't mean you're negative. Right now, I would not even wait. I don't wait for a positive report to start treating patients because it gets too late sometimes. Treatment starts the moment you think you have a problem, the patient has a problem, and the RT-PCR can wait later. There are patients who have had 2 or 3 RT-PCRs negative, yet they have full-blown COVID disease. So
Absolutely, Doc. I think right now we have to take that we're sitting in the midst of a pandemic. I think we can't deny that. So I think one has to say, okay, let's err on the side of caution and just assume you've got, Okay, from Batasha, when can you consider yourself COVID-free without testing?
Okay, let me, this not CDC guide, I'll talk about the Indian guidelines. It's basically, if you have very mild or asymptomatic kind of a disease, then 14 days or a minimum of 3 days of absolute symptom-free period, whichever is greater.
Okay, whichever is greater.
And if you've had a moderate disease where you've had some oxygen shortage or you have needed steroids, then 20 days is the standard.
Okay. From Siddharth, my antibody count is 291. That of my wife is above 400. Can we get ourselves vaccinated? Someone said that we should not get vaccinated and wait for our antibody count to go down. What's your take, Doc?
Look, recommendations are going to change. The US with the mRNA vaccines, Moderna and Pfizer, gives a time period of 3 months, 90 days to wait after an infection recovery to go and get your vaccine. But in India, the period was 4 to 6 weeks. But today I was I was informed by some of the doctors on the group that it seems that the government has come out with guidelines that people should wait for 6 months or 9 months. And the thing is, when there's a shortage of vaccine, so
the guidelines are well timed.
I would say in India, for the Indian vaccines, Covaxin, and 6 weeks is the right time. Wait for 6 weeks and then get it. It's nothing to do with your antibodies. You need to build up not only antibody but also against different strains. So the vaccine protects you against a couple of strains of the virus, not just one. You have managed to get one single strain of the virus, so you may have some immunity to that for the next 3 months. But it doesn't mean you're immune to the other strains, and you could get another strain after a month. So it's better to get vaccinated. 6 weeks, I think, in India should be the right period.
Okay. From Sadhna, I had COVID in March with severe bitterness in the saliva. It's still continuing. Also, my sniffing cold is continuing in the mornings with thickish yellow discharge during the day. Is there anything to be done?
It seems that she's developed a bit of sinusitis along with the post-COVID or during COVID, and that would need separate, I mean, that needs treatment for sinusitis. She needs to get treated because it's otherwise going to keep troubling her, and the taste and the maybe even the smell or the taste, the breathing from the nose, all of that will not improve until that is treated.
Okay. From Pankaj, a member in our home reported COVID symptoms 17 days ago, was isolated for 14 days, and was confirmed positive 10 days ago. Their COVID-related issues were limited to body ache, common cold, loss of taste. When would be safe for them to get tested to confirm negative and get them out of isolation?
If they've only had, like I said, mild or asymptomatic illness or mild, very mild illness with just a little bit of fever, little cough, cold, then 14 days from the date of first symptom is more than enough.
Okay.
You don't really need to retest. Retesting is only required for certain people who are immunocompromised or who are diabetics and who receive steroids, because they may carry the virus for longer. But for the average Joe, just 14 days is more than enough.
Okay. From Shivani, Doc, what's the protocol for a person who's on mild steroids and immunosuppressants post-transplant?
Yeah, you have to be very, very careful there. So ideally, again, maximum precautions to not getting COVID in the first place, because you don't know how the body is going to react. Secondly, because the person's on steroids right in the beginning, when they get infected, the chances of having much more multiplication of virus is that much greater. And the more the virus replicates, the greater severity of disease you can have. And so that is a problem. And people who are transplanted are usually on other immunosuppressive drugs also, even stronger ones. So their immune system doesn't react like normal. And that also can cause the problems that develop during or post-COVID to be even greater. So a lot of care is required, a lot of specialist help. You need help from your physician, chest physician, and also the transplant specialist all together to make sure that you come out of this safely.
I think, yeah, the precautions are really, next level for a transplant patient. So definitely be careful. Aman, these days it's recommended to wash your hands repeatedly with soap, but due to this, my brother has got dry hands with red rashes. Is this normal? From Aman.
Yes, it is normal. I would just say that as doctors, I would wash my hands probably 3-4 times more than even the normal person who's washing maybe 30 times a day or 20. I'm probably washing about 80 times a day. So it's use good quality soap with moisturizers built in, and also make sure that you moisturize your hands, because having dry skin is not a good idea, because if you have cracks in that skin, then that lets bacteria and virus directly through. The skin is the best defense you have against infections, but only if you keep it healthy.
Right. Okay, Doc. What to do if post-COVID slight throat pain develops?
Post-COVID slight throat pain, I would think there's just some inflammation left over from the COVID. It could be a little bit of a post-nasal drip from the nose. It could also be because COVID causes swelling in the nose, like it causes swelling everywhere. And then some people have partial nasal blockage. So when they lie down at night, especially if they do a little bit of mouth breathing because the nose is a little blocked, that can cause a constant sore throat. And also if they've had too many medicines, the azithromycin, doxy, all of these drugs cause a lot of gastric reflux, acidity. So it could be just acid reflux also from their tummy coming up into the throat. So they should go to a physician or a ENT, just get the treatment for that.
Okay, Doc, I don't know how to pronounce this next word. What about I'm just going to spell it for you, COLCHICINE, to disrupt the cytokine storm?
It's just there are so many drugs to stop the cytokine storm. The problem with all of them, you have to understand, is that most of them are not proof. For example, tocilizumab, it's a big name, a lot of recommendations. And now the latest report that came out with a large study shows that it doesn't have any effect. It doesn't save people, it doesn't save lives. So what happens is that these drugs which you are talking about, there's Bactinib, and these are all very strong immunosuppressive. So what they do is they shut down your immune system so that it stops reacting and thinking that it gives time for all the inflammation to settle down. But the problem is that the moment you stop the immune system from working, other infections set in. So a lot of these patients who are given these drugs end up with secondary bacterial, secondary fungal infections, and some of them, and these are all admitted patients in hospitals. So most of them are hospital acquired infections, and hospital acquired infections are usually strong infections who have been around the hospital a couple of times back and forth. So they're resistant to all the drugs that are available and multi-drug resistant. So that's a big problem. So I would say that if you look at technically worldwide, there is no, other than steroids, anticoagulants, uh, nothing else seems to be actually effective. The plasma therapy has now stopped. It's nowhere they were not giving it anywhere in the world except India.
Yeah.
Thank God. And so when I speak to their doctors, who my friends who are dealing with people in the ICU and otherwise, they tell me that, when things look bad, we throw everything at it. We throw everything at the patient and we just hope something sticks.
Yeah.
And that's all they have, because what can one do at such a situation?
No, I think everybody, we're all shooting in the dark. It's so new, but I think, everybody still managed to, develop some protocols and through their experience, what's working. So I think it's tremendous what everybody's, managed to do, Doc.
The problem with this virus also is proven to be very, how to say, cunning, because it has changed. It's not the same as what came in the first wave. The first wave and second wave are totally different. Behavior of the virus is completely different. It's hitting
the progression,
hitting the respiratory system much earlier. So, and when it comes back again, it's going to change again. So we have to be ready to adapt very quickly as doctors and physicians to this. And I think all the public can help best by just keeping at home and staying safe.
Staying safe
in the first place. You cannot believe the way some of the doctors have been working, 12-hour shifts, 14-hour shifts, and they're like,
Doc, we know you don't have an off. I know that for sure. I know that personally. You never have time off. Okay, Doc, we'll just take 3-4 more quick questions from Lata. What precautions should one take if you are back home from ICU post-COVID? And in brackets, plasma transmission also done as part of the treatment. Yeah.
No, once you're back home, you're in a safe environment. And if a couple of weeks, if you get through the next 2-3 weeks without developing any infection that you may have picked up, then you're going to be fine. If you have any nasal issues, salt water spray, a little bit of moisturization goes a long way in preventing any other complications from that end. Most of the patients, I would assume, are on blood thinners, and they would stay on that for at least a month or so after recovery. And one word of caution also is that a lot of people are on Ecosprin, and some physicians are also prescribing Ecosprin. As far as I have read, Ecosprin doesn't really have much role in this disease to prevent the clotting. You need a better blood thinners than that.
Okay, from Rakesh, actually, he was just asking about Ecosprin. So he was saying, can it be, continued simultaneously by cardiac patients?
So the cardiologists, if a person's already on Ecosprin and now he's got a blood test report with the CRP is going high, D dimer is going high, something indicating clotting, they will go on the other anticoagulants immediately. But the Ecosprin is not stopped. That should continue, because that is the antiplatelet. Actually, there are big cells in the blood, much larger than our red cells and the RBCs, much larger ones, and they help in clumping together and forming a clot. So it's an antiplatelet drug. But in this disease, not only that, but even the blood coagulation, the proteins that sort of coagulate inside and form a gel layer and close, even that has to be stopped. So you need to give both to those patients.
Awesome, Doc. From Angad, I got it in November, but from that time my nose gets blocked. So I have been using nasal sprays daily. Is it safe, or are there any alternatives?
It's very safe to use steroid nasal sprays, and I hope that's what he says when he's using them, because if he's using the decongestant nasal sprays like Ortolan, Nazivion, then he's going to get permanent nasal blockage and he won't get better. He needs medication. So you can use steroid nasal sprays. They are very safe and they will help open up the nose. But I would always suggest do it under prescription, because you need someone to actually tell you or understand why they want to give it to you, and then you should use it, not just start using it on your own. And if he's not able to kick the habit with the decongestants, then he needs to go to an ENT so that they can put him on the right medicine. Some people do need a little bit of oral steroid. In fact, to decrease the turbinage, because the Otrivin or the Nazivion has just swollen up everything inside the nose so much that they just can't breathe.
Okay, so Doc, we've got two more quick questions. How long should we wait post-COVID negative, post-COVID negative report to get vaccinated?
You don't need a negative report to take your time frame. If you have had a mild illness, 2 weeks from the first symptom, you can consider yourself non-infected. And the day your symptoms have completely gone away and you feel absolutely fine, from that day onwards, 1.5 months, and you can get yourself vaccinated. Anytime 1.5 months onwards.
Great. And I think in this, you actually answered another question, which was, how long after recovering from COVID are you still contagious? So you just answered that. 14 days and you're no longer contagious.
Mild illness, moderate illness, severe illness, it becomes a different ballgame, and you need someone to guide you with that. But an average of 20 days is fine for that.
Okay, so if you had moderate illness, you should actually then be careful. I mean, you should stay away from people and be careful for about 20 days. Is that what you're saying?
Yeah. It also depends on how long you received the steroids. So that's it. So every person would have a slightly different figure, but 20 days does give you a very good level of safety.
Doc, I've got one more person who just messaged me privately. Do you think we can answer it? It's just a lot. Okay, Doc, please define what airborne means from Shraddha. Is this virus airborne? We know it is airborne, Shraddha. Can we get COVID from our home gardens and balconies? What is the mask protocol for such areas of the house? And protocol for using air purifiers at this time?
Yeah, that's a good question, actually. Coming from all of it. The airborne is all viruses, all these respiratory viruses are airborne. All of them, even the cold virus, the adenovirus, all of these viruses, flu virus. So basically what it means that a person breathing in the same space as you will transmit the infection by breathing out with the virus particles. They'll hang in the air, they'll suspend in the air for quite some time, especially in a closed room if there's no ventilation. And then when you go in there, even after 20 minutes and you breathe in the air, you can get an infection. So the primary thing is ventilation. Coming to infection from balconies and terraces, it's very unlikely unless you have an adjacent terrace where another 2 or 3 people are at the same time standing and they are less than 5-10 feet away from you and they have COVID and they're breathing out and you get it. But otherwise you are safe on a balcony. You're safe as long if there's someone else comes out of the adjacent balcony, then wear a mask or go in. That's it. And if both the people who are out on the balcony, if they maintain a distance of at least about say 10 feet or 12 feet between them and they're wearing simple masks also, the chances of infection would be probably 1 in a million. Air purifiers. I think air purifiers have a very good role because they remove particles down to that size that actually it would clean up the air in the room, including the virus. So a good quality air purifier should be kept on in the rooms, but it's not going to protect you from getting an infection from another person. It's just to keep the air cleaner. Because if a person comes and breathes in your room in the space, then the air, by the time the air gets purified, depending on the CAGR, that may take anywhere up to 30-40 minutes. By then you are already picked up and breathed, taken in the breath and got the infection.
Absolutely. Doc, that has been absolutely brilliant. Thank you so very much. It's really been an amazing, almost 1 hour with you, Doc. Thank you for giving us that extra time. But this is what I said at the start, everybody, he's amazing and he goes over and above the line of duty and you've really been fabulous. Thank you so much, Dr. Shalabh Sharma. And we will share your coordinates with people. And in fact, can we please do that on the chat? Can I request Shivani, if you can please share Dr. Shalabh Sharma's coordinates on the chat, that would be very good. Thank you so much, Shalabh. It's really been a pleasure. Shalabh and Shikha, both dear friends as well, and they're really amazing as a team. Even in our community, they've been fantastic. Thank you so much. So tomorrow we have with us Miss Anviksha Tripathi Jain. The talk is going to be Talk to Me. It's COVID and it's about mental health, and she's leading our initiative at IWN on mental health. So once again, we will be back tomorrow at 5:30 p.m. Do join us for Need of the Hour. Thank you so much.